All right, good morning, everybody. I'm going to introduce our invited guest speaker today. So I'm so excited to introduce to you my colleague, Tatiana Deveney. It's a rare thing in ophthalmology when you go to a meeting and you find your twin. So Tatiana Deveney is a clinical assistant professor at the Department of Ophthalmology and Visual Sciences at the University of Michigan. And so she splits her time between active neuro-ophthalmology clinical practice and staffing the inpatient hospital consult service, which is, again, both adult and pediatric emergency room consultations. She's passionate about medical education and is involved with trainees of all levels, from designing and leading ophthalmology curriculum for first-year medical students and acting as associate medical student ophthalmology clerkship director. She also is the consults rotation lead. So after her, I need to breathe. She completed her undergraduate education at the University of Chicago, and then after that proceeded on to the University of Rochester School of Medicine and Dentistry. During medical school, she was awarded the Doris Duke Research Fellowship and went on to ophthalmology residency at the University of Michigan, where she continued as a graduate chief resident and the neuro-ophthalmology fellow. So in around 2022, she took over the consult service from Jonathan Troe. She grew up in Manhattan, and her residents know she is coming because she's always dressed to the nines in the hospital at the bedside, wearing her wedge heels, and you can hear her clicking through the halls. And then she'll speed off in her Jeep Wrangler home after another long day of consults. So I'm excited to introduce her. We're going to start by talking about some really great consults cases because, consults brings the heat. We know it's interesting. It's always challenging. And then I'm going to talk about a service line update for consults, and then we'll finish with our global ophthalmology speaker. So, Dr. Deveney.
Well, thank you so much for that introduction. I'm so excited to be here. Should I plug this in?
Oh, no, you don't need to.
So I just share my screen. Is that?
Oh, that's right.
So, settings.
Leave meeting.
Yeah.
So how do I reopen Zoom again?
Just hit enter. Or maybe it's back.
Shout out to Ethan. Thank you for the help.
So welcome.
Does that? How about that?
There we go.
Success? Right. Well, I will get started here. So I'm Tatiana Deveney. I'm absolutely delighted to be here. Thank you so much to Theresa and the University of Utah. So I help our consult service, and Theresa's not wrong. We see the cool cases. So I hope these are interesting for you. I love a little audience participation. If you have questions or comments, throw it out there, interrupt at any time. No financial disclosures. So we're gonna do some cases. I am a neuro-ophthalmologist. I'm gonna warn you. So there's some neuro-ophthalmology in these cases, but I promise we're gonna get some retina, we're gonna get some orbit, some anterior segment. We've got something for everyone, okay? And then I thought I'd leave us with a little food for thought. What does emergency department and inpatient ophthalmology care look like now? And what should it look like in the future? So hopefully as you go about the rest of your day, maybe some ideas to think about, and maybe we have some people in this room who have some ideas for kind of new ways of doing things. All right, our first case, a stat page, urgent evaluation for papilledema, need for VP shunt. So I don't know about you, but we don't get a ton of stat pages in ophthalmology. So that's one of the nice things. So this one does not sound good. If we're talking about surgery, this cannot be good, okay? So we run up to see the patient, 24-year-old referred with a concern for idiopathic intracranial hypertension. 1 week prior, she developed double vision, and then a few days later developed blurry vision and went to her local eye doctor and was unable to see even the large E on the chart. Not good. Sent immediately to the hospital with a diagnosis of papilledema. And they did an MRI and an MRV that were reportedly normal. And they got a lumbar puncture with an opening pressure of 32. So high, but not sky high. And they did have some difficulty with that test and normal CSF. So far we're hitting a couple of IIH key points here, right? We've got an MRI, we've got papilledema. Sounds good. Well, let's go see the patient. So the first thing we notice is that that patient is confused and forgetful. She's not telling us anything, her family is. So, our residents in the back, give that a pause. The neurology exam is otherwise unremarkable. The blood pressure is normal. The vision is indeed reduced, 2200 in the right eye, 2400 in the left, no APD, constricted fields, reduced colors. This is a representative photo, but we do have some optic disc edema, some hemorrhages, but that's not the whole exam, right? So we're not gonna run just to the back of the eyes. What about those eye movements? Let's take a look here. So does anyone want to shout out what they see just in the first few seconds here? There are no wrong answers. Oh, I heard it. Someone say it. Nystagmus, right? Uh-oh. And we're going to try and have her look around here. And again, I know this is a little bit of a shaky video, but what you've noticed is that those movements are not totally full. So I don't know about you, but when I walk into a room and I think one thing, and then all of a sudden I've got all this new information, I think we got to walk outside and put our thoughts together, all right? So what do we have here? We have altered mental status, reduced visual acuity, nystagmus, motility deficits, bilateral optic disc edema. So I'll pose this question to our audience. Do you think this is papilledema? So that means optic disc edema secondary to increased intracranial pressure. Is this idiopathic intracranial hypertension? So what do we think? Everyone think we're on the right track, or maybe we should think about some other things? So what does everyone want to do next? What's our favorite thing in neuro-ophthalmology, in medicine in general? What do we do when we're not sure? We do scan. We go back to the chart. Yes, we're going to get more history. So let's go back and look at that chart a little more closely. She underwent gastric bypass surgery 1 month prior to this. She has been unable to tolerate food or medication since surgery and has lost over 50 pounds in 1 month. And someone else shouted out our next favorite thing. We got to look at that MRI. They said it was normal. Let's take a look. So I always want to think about MRIs. What am I looking for? Why did I get the scan? So a couple of things we want to look at initially. We thought this might be high intracranial pressure. Are there findings of that on the MRI? We know that's not perfect. Patients don't have to have that, but there are no findings. We don't see that globe flattening. We don't see those dilated, tortuous optic nerves. And then when I think vision loss and optic disc edema, let's not forget about optic neuritis. So we're going to look at those optic nerves and see if we see enhancement, and we don't. But let's take another look at that MRI. I'm going to give us an arrow sign here. Anyone have any idea what we're pointing at in these pictures? I know we just had O-caps. Any kind of significant parts of the brain I'm kind of highlighting here? Mammillary bodies. Anyone ring any bells there? So let's see if we can put all this together, okay? So again, we're going to see if we can put all these findings together. Altered mental status, reduced visual acuity, nystagmus, motility deficits, bilateral optic disc edema, gastric bypass surgery, not eating, weight loss, and we've got thalamic and mammillary body changes. Anyone want to shout out what they think the diagnosis is? You got it, A+. So this is Wernicke, okay? And that's a picture of Dr. Wernicke. And so we all know that classic triad, the altered mental status, ocular motor dysfunction, imbalance and gait ataxia. But the key here is that this is a clinical diagnosis. You do not need to have all of those 3 findings. And the eye findings can be crucial here, but they can be subtle. If you don't look, if you don't think about it, you may miss it. So things like nystagmus, motility deficits, and yes, even optic disc edema. So this was described in Dr. Wernicke's original report. And if you like to read history, this has actually been translated from the German, and you can go read the original paper. But he described optic disc edema with hemorrhages in his original cases. And vision loss has been described with this as well in about 2 to 4% of cases. Although that may not be an accurate representation, the other findings may take such priority, the mental status, that vision may actually not be assessed in some patients. So why does this happen? You thought that Krebs cycle was something you'd never have to think about again after medical school, but here it is. Thiamine is an essential cofactor, and we don't make that. We have to eat it, and we don't have very much store. We only have stores for about 18 days. So if we don't have that storage, thiamine is denied, metabolism goes up, energy crash, and you get these findings. So I thought what was interesting to start with this case is that sometimes we get these diagnostic dilemmas. We're saying, gosh, it's one thing. This could be in clinic or in the hospital. They tell us it's one diagnosis. We want to think hard and make sure we're on the right track. Yes, this was a young woman with optic disc edema, but vision loss, does that happen with papilledema? It does. It's not common. Weight loss, that's a treatment for IIH. This patient got worse with weight loss. Nystagmus, mental status, those are not going to be features of IIH. And that lumbar puncture, the opening pressure was high, but not very high, and maybe that positioning was a little bit off. So we gave this patient IV thiamine immediately. We repeated the lumbar puncture. It was a normal opening pressure. A day later, totally new person, mental status improved, vision is 20/40. So keep optic disc edema on your list when you think about differentials. Thiamine deficiency can be a cause. This is a treatable emergency. There's not that many things that we can treat right away and that we should treat really quickly. And this is one of them. This is a clinical diagnosis. You don't have to wait for that blood test for thiamine. That can take days to come back. And remember, we all know this, but sometimes we walk in and we think, okay, we're here to look for papilledema. We go straight to the papilledema. There's so much more to that. Pick up on those subtle clues. And when in doubt, that history, that chart review, that's your best friend. You're going to get more information. All right, so A+, we started our day off strong. There goes that pager again. Okay, I don't know about you, but our pager goes off all the time. Do you still have pagers? We still do. So now we've got another case, transient vision loss. Whew. This one sounds a little simpler, right? We get 1 or 2 of these a week, transient vision loss, do an eye exam, they're here for a stroke workup. This one sounds like we've got it, right? Let's see what we've got here then. 71-year-old coming in, 2 episodes of transient monocular vision loss, and was referred in for a stroke evaluation. Vision came back after a few hours, pre-diabetes, hypertension, otherwise healthy, and just had an eye exam. They said it was absolutely normal. Neurology's already been called. They're doing a stroke workup. The CT, CTA are unremarkable. Page to ophthalmology. Vision loss just reoccurred. Can you come evaluate ASAP? So I don't know about you, but you may be thinking, really? They just had an eye exam. They want us to come look again. But I will tell you, you will never regret going back and taking another look. So let's see what we've got here. So the patient says, gosh, it's not vision loss. It's blurry vision. And it usually lasts a few hours, but now it's really blurry and it's not getting better. And what really bothers me is my eye is hurting. It just has this ache to it. And my only eye history, I had cataract surgery a couple of years ago. It was perfect. I don't wear glasses. I could not be more pleased. I'm 20/20. So let's do our exam. And this is the first thing we see. Uh-oh. So what's that? Normal, not normal? Right, that looks like blood in the eye. That's a hyphema. Okay. And the vision is hand motion. So yes, indeed, it is blurry. The pressure's normal. We know from the old exams and from our B scan, there's no fundus abnormalities, no neovascularization. So show of hands, who thinks we're on the right track doing a stroke workup here? Right. Who thinks maybe we should consider an alternate diagnosis? Right. Anyone want to shout out what that could be?
It was originally called Ellingson syndrome way back in the day.
So any ideas what we call that now? Oh, is that? All right, we got it. So this is uveitis glaucoma hyphema syndrome. That hyphema cleared with treatment. Here's that transillumination defect. Look at that up to the top. And gosh, if we overlay a lens to that, so that's a transillumination defect from a haptic. The IOL was actually not fully in the bag. We could see that on the UBM. So that was causing these recurrent episodes of vision loss and eye pain. So uveitis glaucoma hyphema syndrome, I said I would get to you, anterior segment surgeons. So intraocular lens in contact with the uveal tissue. This can occur years after cataract surgery. So we got to keep that in mind, even if that cataract surgery was years ago, and can present with pain, photophobia, decreased vision. I like this. This is back in the 1980s, the early days of intraocular kind of lenses. This was even described then. So we've known about this for a long time. So this patient underwent a lens exchange, 20/20 postoperatively, no more transient vision loss. So not every transient vision loss do we go straight to stroke. Careful attention to that slit lamp exam, and TIDs can be a little bit challenging. You take a quick look with a portable, but really spending the time to look for that finding, you're going to catch this and figure out what that cause of the vision loss is. All right, we are having a good day on the consult service. Tell me, residents, have you ever gotten a page like this? Patient has eyeballs. Please do an eye exam. Okay, we get this too, okay? I'm going to tell you that sometimes there's something interesting there. So our next page, we had a busy day. My gosh, these 2 consults. Please do an eye exam, help us, okay? So sometimes we get this. Let's see why they want our help. So 20-year-old transient paresthesias and aphasia. MRI's been done. It looks like subacute small embolic ischemic events. You name a test, it's been done. Vessel imaging, echocardiogram, labs, everything's normal. And the patient says, I don't know why ophthalmology is here. I don't have any vision loss. But I mean, I guess you're the eye doctors. I mean, occasionally I get this like flash of light in my vision, but that's normal, right? I don't know why you're bothering me. We do an exam. It is indeed normal, 20/20, full colors, no APD. But we take a look in the back, and this is the only finding on the indirect exam. So that is a single cotton wool spot in the right eye. So let's take another pause. We got called to do this eye exam. This patient's having strokes. We're not sure why. We see a cotton wool spot. We can run through our huge list of cotton wool spot causes. Should we be done? Do we just say, I don't know, it's ischemia? Any other testing we might want to do? Anything else to consider? Okay. Gotcha. Let's say that's normal, negative. Any other, oh, I like that. Let's get some additional studies in our retina clinic, right? So we've got a young person in a cotton wool spot. We don't have a cause. So this is some snapshots from the FA, not normal. I'll tell you the filling time was normal, but we can see, look at those vessels lighting up, and there's some areas of non-perfusion. So that wasn't totally apparent on the initial eye exam, but we can see on that FA, we have got some abnormalities on that please help us eye exam. So let's take another look, and I will give full credit to our residents for really putting this together. We've got paresthesias and aphasia. We've got a vasculitis. Our very astute resident says, by the way, do you have any hearing problems? And the patient says, I'm so glad you asked me about that. I have been having some trouble with my hearing. In fact, we get audiology testing and there's some sensory neural changes. We go back to our MRI, again, neuro-ophthalmology. We take a look at those embolic phenomenon and we see that there's some changes in the corpus callosum. OCAPs just happen. Any ideas how we can put together MRI, neurology changes, vascular changes, hearing loss? That would be Suitcase syndrome. Okay, you got it. So again, a screening eye exam takes us in a whole new direction. This was initially described in the 70s, but coined in the 1990s, an autoimmune endotheliopathy. We have another triad, lots of triads in ophthalmology, hearing loss, branch retinal artery occlusion, encephalopathy. But again, you don't need all of those. And you just have to be really attuned to this, picking up on those subtle changes. We know that patients can have no eye symptoms, right? If it's off in the periphery, maybe they don't even notice they're having those vision changes. And we can see branch retinal artery occlusions and gas plaques. So this patient was started on immunosuppression, followed by neurology, rheumatology, our uveitis service, doing very well, 20/20 vision. So yes, even when we're tired, even when we can't believe they're asking us to do an eye exam, just because we can actually pick things up. So if you have that attitude, you will catch things and really help make that diagnosis. Careful attention to the history and the subtle eye findings can really lead you there. And this absolutely changed the course of management for this patient. So yes, even those screening eye exams can have value. All right, we're gonna do one last case. It's ophthalmology. We cannot get away without talking about a red eye, right? It's our favorite topic. 60-year-old woman, unilateral red eye for 6 months, worse in the past 2 weeks, swelling, chemosis, double, oof, associated with a headache, mild hypertension, no autoimmune problems, no trauma. She's been to the ER for this a couple of times. So they said it was a migraine one time, a subconjunctival hemorrhage, and she's been to a lot of eye care providers as well. So you name an eye drop, she's been on it. Steroids, antibiotics, it's not working. The redness persists, it's getting worse. That double vision, it was fluctuating. Now she's having constant double vision. So not good. We got some red flags here. We take a look at our exam. Vision's good, but the eye is proptotic. The eye does not move. That pressure is sky high. And you can see this kind of chemotic, and it's a little bit harder in the photograph, but a little bit red eye, normal fundus exam. So we get a CT. Anyone see anything on this CT? Normal, not normal? Normal. So got some large muscles there, right? Okay. But let's take a closer look. We get our imaging, okay? We see something else there. Let's see if we can take a look here. See if anyone shouts out. Do you see any differences between the two eyes? Yeah. Oh, I heard it. So that was the question here. You know, the initial CT looks like orbital inflammation. I told you we'd have some orbit for our orbit surgeons, but fistula is on the list, right? She'd gotten a dose of steroids. It didn't do anything. We phone a friend. Let's talk to our neurointerventional radiology group. They agree. There is definitely some asymmetry there. Angio shows a right carotid cavernous fistula successfully embolized. So we all know about carotid cavernous fistulas and all of those symptoms that come along with them, the classic corkscrew vessels. But remember, sometimes these can be a little more subtle. The pain, the double vision, the chemosis. Beware that chronic red eye that you've tried all those drops for. We want to at least make sure we're considering this. What about the muscles? That's actually been well described in fistulas, so don't be deceived by that. You can have large muscles, and that's been described in a lot of these cases, the idea being sort of congested muscles. But again, look at those superior ophthalmic veins. The asymmetry there can really help you make that diagnosis. Day one, she feels great. A month one, it's as if it never happened. Totally normal eye exam, feels great, red eye, gone. So those are some cases. That's a busy day. That's the start of our consult day. But I think the key here is that all of these have a common theme, that ophthalmology involvement really can make a difference in the hospital. For all of the dry eye consults we get, that we have cases where we can really help direct management and make a difference. So that's what I want to end here in this last couple of minutes, just giving us a little food for thought about what should ophthalmology care look like in the inpatient and emergency room setting. So we can help. Hopefully I'm not convincing you of that, but we've actually looked at this. We know that having input from ophthalmology, neuro-ophthalmology can be of value. I am a neuro-ophthalmologist, so we've looked at a lot of our consults in the ER for double vision, for pupil issues, and the answer is we can help make that difference. So in 100 cases for double, we looked, there were 14 unindicated and 20 incorrect imaging studies ordered by the emergency room, the most common being a head CT, which is not going to be the first-line test for almost anything, and a lot of times that imaging study for the blood vessels was omitted, which is so crucial for a third nerve palsy. Same with pupil abnormalities. So that large pupil that walks in, the most common cause of that wasn't herniation, that was a pharmacologic pupil. We had a wave of this induced by glycopyrium, or Qbrexza is the brand name. I don't know if you saw a lot of that here. It was a sweat wipe, an antiperspirant wipe that you get on your fingers and then touch your eyes, large pupil. So we had a whole wave of that coming into the ER for anti-cicoria. But the key is that our exam showing this is pharmacologic or that this is post-surgical can help save that testing we don't need. So we know that we can help and that we have value. And for our residents and everyone in the audience, that there's really room to help advance care, that we can do things with emergency care and emergency room inpatient care that really can add value in addition to everything we do in our clinic setting. So we're looking at temporal artery ultrasound for giant cell. The idea being, are there tools we can use that are less invasive that can help give us a more rapid answer? And we're trying to figure out where this fits into our screening with patients with giant cell. But that's really the prime place to do it, is in the emergency room and inpatient, where we're seeing a lot of these acute giant cell concern cases. I don't know if everybody saw this recommendation a couple of years ago that came out of a lot of work on inpatient care, that the AAO came out and said screening for Candida in an asymptomatic patient is a low value test. So that was based on a lot of research done, looking at a lot of consults, and there's a recommendation now saying screening all these people who just have a positive Candida blood culture really is a low value add and really probably isn't adding much if they don't have signs and symptoms. So that's research done in the inpatient setting. And I am passionate about quality improvement. If that is a passion of yours, gosh, are there things we can look at in the hospital? So taking the lead on preventing exposure keratopathy in the ICU, we really can help come up with protocols and help our patients get out of the ICU with nice, perfectly healthy eyes. So obviously, I think ophthalmology has a role, but I know what you're thinking. There is an elephant in the room that we have to address. And our residents are in the back. And I know you're thinking, I am really busy. And we have a lot of consults. And I am not going to disagree with you. So this is the University of Michigan data. The blue is adult emergency room consults. The orange is all consults. That graph keeps going up and up and up. So in 2017, we had about 1,000 adult ER consults. That's going up to more than 2,000 the last year we looked. So nothing to suggest that this trend is going to change or reduce. That's even with COVID, things are persistently increasing. So that is definitely something we have to think about. We cannot ignore that. That trend is increasing. I'm curious to see what Utah's data looks like, but I wouldn't be shocked if this is a national kind of thought that things are going up and up and up. And this is the state of Michigan. And like Utah, we are also a tertiary quaternary referral center. Michigan is a big state. So I circled Ann Arbor here down at the bottom. We get patients all the way from the Upper Peninsula. That's almost 450 miles away. So in addition to all of this and consult volume increasing, we're also trying to take care of a huge population of patients who may not have ophthalmology access locally. And I know Utah has that same issue with people coming in from very far away. So this has become a really big topic of conversation. And again, love to talk more about this at any point. And I encourage you to read these two articles. This is in iNet, the AAO magazine, Who Takes Call and Why I Take Call. But this idea being, are we seeing kind of a reduction in people taking call locally, meaning do emergency rooms not have an ophthalmologist they can call? And there's a whole variety of reasons we could talk about for why that is. I don't think it's just one thing. And then do people take call and why do they take call and what does that look like? And really, what is our role as ophthalmologists in providing this emergency care outside of our regular clinic settings? So I think, and I challenge all of us, I think it's time for some big ideas. And I think there's really some opportunities here to try some things. So I really want to shout out to the Emory Group for taking the lead on this. But we have incredible imaging in ophthalmology. I mean, we have the best photography in the world. We need to be thinking about how to use some of this amazing technology to help us screen some of these consults, either in our tertiary centers, so we can help triage and decide who needs to be seen right away. But I actually see this, maybe this is in the local emergency room and we do a telemedicine consult and we look at that picture with them. So people have looked at retinal artery occlusion diagnosis, papilledema rule-outs, retinal detachment. Think about the number of things we can confirm by just having a fundus photo and an OCT. Portable visual fields, I know you have that here. Think about that. We're taking that visual field test that used to only be accessible to us in a clinic, and we're letting anyone do that in the hospital. Patients in the hospital often can't sit in a chair. They can't come to clinic. We can get that baseline testing our neurosurgery colleagues are often asking for, but we can make a rapid diagnosis of a homonymous hemianopia. We all know that may be really challenging on confrontation. So think about these big ideas. How can we use all of this technology to help with that consult volume? And new ideas. So my colleagues at the University of Michigan have developed a lightweight camera system to record pupil exams. This is 3D printed, easy to use. Think about how nice it would be to have an actual recording of a swinging flashlight test, an actual picture of the pupils. You could look at that at home. You could review that with a senior resident if you're a junior resident. So how can we use this technology and really help us triage and better kind of work through consults? And to our residents there in the back, there are no such thing as small ideas. So we looked at our consult bag a couple of years ago, and it was a black box of just stuff. And we redesigned that and 3D printed compartments. Yes, that's a Maddox rod for our double vision exams, and put spots in for drops just to make that easier. Think about just a minute or two saved on trying to find things. We know that sometimes it's hard for patients to hold a card, hold a pinhole, put the glasses on. What if we put that occluder right on the glasses? That's 3D printed. So these are not huge, big money things, but even small ideas. I encourage you, think about everything you do every day. Where is there room to maybe make some changes? And finally, I'm passionate about education. I think we also need to think about how we educate and think about consults. So we absolutely can have consults be a foundational experience. I will tell you, my very first day as an attending, nothing prepared me more than having seen patients in the emergency room, working through a new challenging diagnosis. So as much as that overnight and all those consults, I promise you, it's going to help you when you get to clinic with whatever you do. And we also have a role in really helping our non-ophthalmology colleagues. So we are in the process of doing a couple of sessions with our ER. The next one they asked for, neuro-ophthalmology in the emergency room. And I would love to chat with them about how to approach that in a way that's easy for them to understand. So we looked quickly, just did a needs assessment. And what we realized is reading the BCSE is great, but that's really not going to target what we need for on-call. So we redesigned our entire curriculum. We have far more cases and discussion focused on things like, how do I examine a kid in the emergency room at 3 o'clock in the morning? So we had our peds folks help us out there. Neuroradiology on call. How do I look at a CAT scan? Post-operative issues, and very hands-on. How do I measure double vision in the middle of the night? How do I do a canthotomy cantholysis? Really making that practical. And we're gearing up to start our consult corner. The idea being that you get a very quick hit of information after you've seen a consult. So you get that reminder, oh, gosh, I saw a central retinal artery occlusion. You get a couple of quick facts and a key article. We're trying to link this to the EMR, but the idea being giving you a little bit of a reminder, a little bit of boost in teaching right after you see something. So lots of ideas here. Hopefully this generates some excitement. And the idea I want you to walk away with is, what should this look like? How do we handle all of these consults? So 4,385 consults in our last academic year. Keep in mind that is only new consults. That is not the follow-ups for orbital cellulitis that we see every day. So how should we handle that? What new ideas can we come up with? And if you're interested, and hopefully we have some people who want to be interested in hospital care, please consider joining the Ophthalmic Hospitalist Interest Group through AAO. Donna Kim is just incredible out of Oregon, but absolutely things to learn there. And so I'll end there with an absolute thank you. It's been so fun to be here. So thank you to Theresa and the University of Utah. Absolute thank you to colleagues. All of those cases were multidisciplinary. One of the joys of consults is getting to work with medicine and neurology. And I absolutely want to give a shout out to our residents, but I want to give a shout out to our residents here in the back of the room. Thank you for everything you do. It does not go unnoticed, and you are absolutely providing a critical service. So I want to thank all of our residents who do this care on call. It's absolutely essential. Every single one of these cases, our residents were absolutely instrumental in helping make that diagnosis. So I want to thank everyone there. My email, Theresa has my phone. Call me, message me. Let's think about some new ideas. I think we can do it. Thank you.
So I have to thank Bob Hoffman for thinking about coining the title of my presentation. So when we were residents running around the hospital, have Suitcase, will travel. And so a Moran consult service line update. I have one financial disclosure. It's not relevant to this talk. So it was 4 years ago this month that I presented my PGY4 grand rounds in 2021. Is there a doctor in the house proposing that we needed an ophthalmic hospitalist here at the University of Utah? I'm excited to talk to you about the journey, but we talked a lot about these same issues that were presented today, the burden of on-call, the transfers that are coming more and more to academic medical centers. Do you guys have your transfer center data?
We do.
Yeah, so what we noticed too, and I just got this in the last couple of weeks, is that COVID changed our healthcare system and our ophthalmology healthcare system. And so we're collaborating with several academic sites to look at our transfer center data. And after COVID, those numbers are going up. And we know this because on faculty call, we've had conversations about the difficulties taking those transfer center calls. Is it the right thing for the patient to come from 3 states away all the way to the University of Utah to get care? So in 2022, I was going to say the consult service was born, but it was really always there. And so I really think it just got reincarnated. So what's really changed since then? Well, the hospital has continued to grow. So many of you noticed the new building up on the hill. We have the Kirk building. So the grand opening was in May 2023. This increased inpatient capacity to the Huntsman by 50%, added an additional 48 beds. Huntsman was wonderful. They purchased a new slit lamp press, which is up there, which has been absolutely amazing to screen patients with primary CNS lymphoma for intraocular involvement. So we really appreciate collaborating with them. Our hospital bed numbers, so here's what they were before, so around 864. So it's interesting when we compare our consult numbers because we have similar bed sizes. And so with the addition of the Huntsman, we went to around 912. So from an area space, we're pretty similar. In addition, the Lehigh campus opened up. So that was in February of 2024. This is a pediatric level 2 trauma center. And so, you know, our pediatric emergency medicine colleagues, we've always been here. We're right next door. And this really changed things for them because in a level 2 trauma center, ophthalmology is not in-house. And so we were able to work with them on collaborative protocols. They also purchased an eye care 200 in both locations, which was great. Previously, before they hadn't had a tunnel pin. And this is so helpful to detect compartment syndrome and help triage, eye concerns. And it's great in kids because it can be used in the recumbent position and it doesn't require topical anesthetic. So huge thanks to Mimi Young and Griffin Jardine, who have really led the endeavors there with, how our call and consult system works. So the question in the room, everything's wondering, how does the consult volume look here? Well, it's the same. So this is our University of Utah billing data for the adult ER. So this is going to cover the Huntsman, the inpatient rehab, and the university hospitals and emergency departments. You can see the red is the number of ED consults. This is from 2018 to 2024. Our inpatient initial, our inpatient subsequent, and then the total number of consults. So thankfully, we're not quite as busy as Michigan. So again, that positive trend keeps going up. What about the Children's Hospital? So I had to go back and look at note level data for this. So this is 2013 to 2025. So each graph is the number of patients with an initial consult and the number of encounters with an initial consults on the left and right of each pair of graphs. But you can see the trend too, from 2013 to 2024, the numbers just keep going up. So, initial consults are around 300, and then subsequent consults around 800, and then subsequent consults around 300 from that. So what about if you look at where, sorry, I can't see my slides in presenter mode. I had it all there. What about if you look about where we see those consults? So very, very interesting. So this is 2013 to 2025, so about early 2025, which is why you can see a partial year. The red line is the emergency room consults. The dark blue, the red line is the inpatient consults. The dark blue is in the emergency department. The hot pink was null. So you can see that with the switch over to Icentra in 2018, the number of kind of classified consults we had dropped, and then the pink is in the PICU. And so something also changed with COVID. So you can see that dip around the time of the pandemic. And then after that, things have just really taken up. And then similar data, when do we get those consults? This is again for just primary children's hospital during the, at note level data. This is just for 2024, and you can see the bar graph along the bottom left. And so there's consults that come kind of after business hours. It tends to be kind of consistent with how many we get after business hours versus the ones we get during business hours. And you can see there's a month-by-month fluctuation. So you can see a large increase in February and April of every year, which is really interesting. And then when you look at note types over that same time period, in the lower right-hand corner, you can see that the small gray line down at the bottom is H&Ps, and so those are going to represent the open globes that we do. They tend to occur more in the summer months. And then also the pink line is the number of follow-ups per month. There's a big peak in July, so maybe we've got new residents. They're anxious to follow up and make sure they see the patient again and again so they know what's going on. And then the ophthalmology consultation numbers by month. So I don't have this granular level of data for the University of Utah data together. What happens if you put that primary children's data on a bar graph? Very similar. Again, the trend is increasing and increasing. And then together, kind of what do we look like? So that was the University of Utah data over again with ER, inpatient, and initial, and then the total number of consults. And then together, it's kind of interesting to look at. So the emergency room represents about 1/3 of our business. Inpatient initial consults are about 1/3 of our business, and follow-ups are about 1/3 of our business. And overall, I would say about 1/3 of the consults also come from the Children's Hospital when you look at different locations. So we've had a lot of different educational initiatives as well. We've really started collaborating with the adult emergency medicine and pediatric emergency medicine teams. So I teach slit lamp skills and eye vitals to them every July as part of their orientation. So they get an hour lecture on eye vitals, and they get a hands-on skills lab, so they know how to use a slit lamp, know how to use a tonal pen, know how to recalibrate it. And then also with the pediatric emergency medicine fellows. With the opening of Lehigh, we did a big in-service with the adult pediatric emergency medicine attendings at the Children's Hospital. That was 3 hours to kind of provide them more hands-on skills labs as well. And I think this has really been really critical in improving our relationships working with the ER. I think a lot of times, you know, we go in there and it's 2 in the morning and this ER doc is kind of balancing and juggling so many things. And it's really been so helpful that whenever we do get a call, they're like, here's the vision, here's the pressure, I did this eye exam, this is what I'm seeing, can you come help me? Or this is what I'm thinking about. So we've also had some great departmental collaboration. So I did a recent talk with the burn ICU, kind of focusing on orbital compartment syndrome in the burn ICU. We do have occasional cases up there, but fortunately, I don't think we've had anyone who had vision loss, as long as the burn attendings that have been here for many years can remember. We're going to be scheduling a fluorescein skills session with the burn team so we can talk about, have their PAs screened at bedside in patients that have ocular surface burns. And then we also worked with pediatric rehab on neuro-ophthalmic issues after TBI and double vision. The occupational therapists, physical therapists are, we want to make sure that kids with double vision are getting patched appropriately and not when they don't need to be patched, especially when they're in the amblyogenic phase. So Dr. Deveney already talked about this. So the use of new technology. So yes, we have a virtual visual field here. We implemented it right at the beginning of COVID. It still is going. We've had about 700 patients that have had visual field imaging over that time period. So it's about 10 to 20 patients a month. And the clinical pathologies that this helps with has been really amazing. It's been a game changer with the neuro-ophthalmology division for vision-threatening papilledema. Previously, we would have those patients who were in the ICU with their lumbar drain on like 4 grams of Diamox a day coming down to the neuro-ophthalmology clinic to do a visual field. Not great. And now we can go to them and do daily visual fields to see how their visual field deficits are improving to help us tailor the therapy that they need, whether it's medical or surgical, and really follow them closely. Neurosurgery loves this for pre-op and post-op evals. You know, they have somebody come into the ER, pituitary tumor. Do they have optic neuropathy? Are they going to be able to see? Well, we can tell you. We can tell you if they have an optic neuropathy. We can get a baseline visual field, and we want you to have their vision the same and or better whenever we see them back in clinic later. So, and it's also so helpful for transient visual disturbances. I have something funky in my vision. I don't know what this is. Is this migraine? Or is it just a homonymous defect? So screening for that and getting those patients to appropriate stroke workups and expedited stroke workups has been really, really awesome. So just to remind everybody, we do have a protocol for vision-threatening papilledema. It's on Pulse. And so when you're taking those calls about disc edema over the transfer center, that'll be something to remember. And residents, I emailed you yesterday. This is ready to roll out. Who's excited? So we had this years ago with COVID. We had a camera in the ER. So now when we have rollout papilledema consults, we're going to be using a non-mydriatic handheld fundus camera to take screening photographs. If the question is specifically, does the patient have disc edema? So the resident will order the imaging, take the photos. The photos are going to be uploaded to Continuum. And then we'll do kind of a small documentation note in EPIC or in Primary Children's if that's where they are at. If there's evidence of disc edema, the ophthalmology resident will convert to a full ophthalmology consult. But if not, this is going to be really helpful for screening. On a national level, there are multiple academic institutions. We just looked at our papilledema data for papilledema screening. So our actual positivity rate for papilledema screenings is 17% here. So those actually, we do pick up disc edema. I know we have a lot of negatives. And there were cases where it absolutely made a difference, especially at the Children's Hospital. We're going to have the multi-institutional study hopefully coming out later sometime this summer. So look for that. This has also been so helpful for documenting fundus exams in patients that are too sick to come to Moran. If they're up at the Huntsman, they have stuff in the retina, and our consults residence is changing, or there's a different person staffing if retina is seeing them from one weekend to call. And it's very, very helpful for funky white stuff in the back of the eye. Is it a cotton wool spot? Is it fungal chorioretinitis? That's early. I don't really know. Let's just check it and keep an eye on it for the next couple of days. The next couple of weeks. That's really, really been super helpful. So what's on the horizon? As Dr. Deveney talked about, this is going to be a game changer for our department and something we have been working on for over a year. We got funding from the hospital to have a non-mydriatic fundus camera and OCT module in the University of Utah ED. So we've secured a space. We're working on the tech back end lift. And so the emergency department, essentially this camera will be there. It will be mobile. It's going to be so helpful for screening, triage, and diagnosis in various clinical contexts. The emergency department will order the photos. An emergency department staff member will take the photos. And then those photos are going to be uploaded to Epic. And then within 24 hours, just like radiology, ophthalmology is going to provide a formal read back to the emergency room. No disc edema, normal fundus. And then obviously this is something that we can use to treat central retinal artery occlusion because we have that OCT module attachment. So we're going to have an on-call type of system for that. To interpret that because there's great evidence from other institutions about using intra-arterial or intravenous or intra-arterial thrombolytic to treat retinal artery occlusion in the emergency department. So it also expedites care for patients referred for papilledema. So this is a really interesting study out of Emory, and they looked at how long their ER wait times were for patients that were referred for papilledema. And really, this is where the camera is really helpful. You want to detect and catch vision-threatening papilledema because you don't want to miss it, and you don't want the patient to have a diagnosis, and you want to have a missed diagnosis. And we want to essentially get those patients who don't have a neurologic problem, who maybe are having a migraine, treated and out of the ER because ER bedtime is expensive. And this is something that the ER is very invested in. There is the hospital system. There's a high percentage of patients that leave the ER without being seen. And the hospital administration is working very closely on this to try to improve that. There's been an ask, which I'm sure all the residents got the email, but there's been an ask that all services try to see patients in the University of Utah Emergency Department within 1 hour and have them staffed within 2. In ophthalmology, that is a tall order for us. When our eye exam can take an hour, it takes 20 minutes for somebody's eye to dilate, to take a history, to do a visual field. So this camera is really going to help us with that. Obviously, that's an aspirational, goal, and that's something we should move forward to, but we have to think about our residency culture too, and how we can also provide timely care. And I know it's hard. I've been on call whenever you're stuck on the phone answering phone calls. So this is a really interesting paper if you want one to read. So at Mount Sinai, they basically put just OCT modules in emergency departments where there was no ophthalmologist on call and remotely provided a read for the treatment of central retinal artery occlusion. It worked really well. It was really effective. The biggest problem is the patients didn't come in soon enough to get treated. So from a public health standpoint, we really, the stroke mnemonic is always fast, but we've got to make it be fast. We have to include the eyes and the vision changes with that. Just to remind everybody, we also have a protocol for retinal artery occlusion, and we do give IV thrombolytic when appropriate in consultation with our stroke neurology service. So, and this has been something that's made a difference for people. This is a patient that, he came in, rode his motorcycle right to the ER. And so it's definitely something that right when he had vision loss, so it absolutely impacts patients. So what was this like? Really reimagining a growing service. And I think my mom read me this book all the time when I was a kid. And I think this book really exemplifies like what it's felt like for me on the consult service. I think the first year I did things that we did things a way that I thought had mirrored an outside institution, and that wasn't what was going to work here at the University of Utah. And with the help of Rachel Simpson, we really reorganized our resident schedule to kind of prioritize, giving the PGY2s time to learn so they weren't so overburdened with the number of consults they were seeing. Your numbers are insane, by the way. I feel busy. And our numbers are not that high. So I really want to thank the current PGY4 class. You were our first class that went through this, and every year we do a feedback session with the PGY2s that just finished consult, and resident input and resident feedback has been absolutely crucial to developing this. Not only is a service for really establishing and maintaining quality patient care, but it's also about your education. And sometimes I find the hardest feedback to give is the feedback you need to hear and you need to say. And so without these guys sitting down at my dining room table being like, hey, could we change this? Could we change that? This really isn't working for me. We wouldn't be where we are today. And so this year, I'm looking forward to meeting with our current PGY2 class at my house. We'll get food and to see what we want to change, what's working, what's not working with our consult service. Just some photos, it's really a joy. We showed up, we started seeing patients, and I've had a comprehensive ophthalmologist. I've had to grow in places that I didn't see before. And you guys get to see that every day, and every day you teach me new things, and that's probably my favorite part of the job. It's been a real joy to be on this journey. So with that, I'll take any questions.
We have a guest speaker today from the Aravind Eye Health System. We hear about the Aravind Eye Health System. It was founded in 1976 by Dr. Venkataswamy. They are approaching now 100 million clinical patient visits, 10 million surgical procedures, and we are honored to have Dr. Sankarananthan. He'll be speaking to us today on cataract surgery. He's had a busy, short trip with us. We already have a small incision cataract surgery and phaco research collaboration that will move forward. He's held already three video reviews with residents, again, just during this last week. Importantly for the Aravind family watching online, he did represent himself well at our golf outing, hitting several hits about 180 meters out. Now, they weren't always straight, but it was impressive nonetheless. And most importantly, again, has been his contributions to our residents while here. He finished his training at Aravind, and then he currently is the Chief of Cataract Surgery and Training at the Aravind Hospital in Salem. He goes by Dr. Shankar, without further ado, and we do have a little thank you for you at the end. Thank you, Dr. Shankar.
Thank you, Dr. Jeff, for those kind words. I'm Dr. Shankar. I'm from Aravind Eye Care System. So without any delay, I'll just get into the topic. And this is Dr. V, our founder. So our motive and our vision of the entire Aravind Eye Care System is to eliminate needless blindness by providing quality eye care to all. By all, we mean irrespective of whether the patient is able to pay or not pay. So this is the year in 1976. This was the hospital that was first founded by the founding members. This is Dr. V, his sister, husband, who is Dr. P. Nambarmal Sami, a very prominent retina surgeon. Dr. Nambarmal Sami's sister, Dr. Vijay Lakshmi, who's a pediatric surgeon, the first one in India to start a pediatric ophthalmology department. Her husband, Dr. M. S. Srinivasan, a renowned cornea specialist who's been named by Stanford as one of the top 3 scientists in the world, and Dr. V's brother, who's in charge of building up all the 130 hospitals that we currently have, and Dr. Tulasiraj sir, who's the administrator of Lions Aravind Institute of Community Ophthalmology. Now this is 1976, and now this is where we are. We have around 7 to 8 specialty teaching tertiary eye care centers. We currently opened up one in Tanjore, a district that is closer to Madurai, on this Sunday. And we have 7 cataract services center, secondary care center, where we do all the cataract surgeries from trifocals, basic monofocals to trifocals, and we do glaucoma surgery, basic traps, pterygiums, and retina injections. And we have 8 community eye clinics where we see only OPD, like the ones that I went with Dr. Jeff Patty to Park City yesterday, where we just diagnosed them. And then we have 117 primary vision care centers where we have collected through telemedicine, where we use all the eye care tonometries and the non-magnetic fundus cameras. So we get delayed the fundus images on a daily basis to our each and every base hospitals. And so we don't call ourselves an Aravind Eye Hospital anymore. We call ourselves Aravind Eye Care System because we have the entire spectrum of an eye care that's needed. We have the outpatient service. We have the training centers within each and every teaching hospital. And then we have the in-house pharmaceutical industry that is called as Orlab, where we make all the IOLs, the pharma parts, And also we have the entire spectrum of lenses except trifocal. We have our own phaco machines, our own green lasers for retina. And then we have a huge eye bank, which is connected with the central government's of investigation. Like we have 4 of these central eye banks in Aravind. It's totally under our control and not the government part. And this is the LICO. And currently we are around 6,000 people, including our MLOPs and our doctors. So in 2024, 2023, 2024, Aravind had a blessed way. We were able to see 6 million patients and perform 722,000 surgeries on the current year. Out of the 722, 450,000 surgeries were cataract surgery, and rest of them were all specialty surgeries, including lasers and injections. So over the years, we have grown at the average rate of 8% every year, 8 to 12%. And in 1978 to 2024, currently where we are, this is our surgery volume that we are currently having. Out of this, you should see that we are predominantly a free side also. Like when you see initially we were more free, but gradually now India is becoming more developed now. And so we have around insurance patients coming in more. And so we are 50-50 in that area. And then what got us to here? Like how are we able to do this? So mainly in Aravind runs on these values systems. Like we make accessible, we make eye care accessible to all, quality and continuous improvement, patient centricity, self-reliance, frugality, sharing our knowledge with all the people whoever are interested to coming forward to learn from us, and staff centricity. By staff centricity, we mean training our in-house residents, and that is in-house residents and our mid-level ophthalmic personnel, and that is the main reason why we are able to expand in a rapid pace. By that, what I mean is, last January we opened up one tertiary eye care center in Coimbatore, and last week we opened up one in Tanjore, and in another 6 months we are going to do it in my center in Salem. So we are possible to do it because of the in-house training program that we have. And so at least in India, we need at least 100 need an eye care service. So providing access to all is a very big challenge. So these are the centers throughout Tamil Nadu that we are spread around. So there are the tertiary and as well as secondary centers here. So I was telling Dr. Jeff and the residents who we spoke to, currently, if you enter Tamil Nadu through any side in the directional thing, you will head up and around the hospital in 3.5 hours or 4 hours. It can be a secondary center or a tertiary center. So now among the total 6 million outpatients that we had last year, this is the volume that we see in outreach camps. Okay, and this is the volume of surgery that we did last year. And in paying side, who had the capacity to pay, we did 178,000 surgeries. In free, which is a subsidized, like they pay less than $2 for the surgery, which comes to 160,000, say like $100, not even $100, sorry, $20. So this is that group, and people who cannot reach us, like who we have to go in search for, they were compromising around 111,000 surgeries in the last academic year. So now, what do we mean by, sorry, okay. Now, if you see here, on the left, you can see a person who's educated, who is in the city, who's within the city, who can reach eye care. And on the left, you can see a female who is not literate, who is in the extreme remote area, who's not able to access to healthcare, and she is entirely dependent on someone to come and bring her to the hospital. And so she delays eye care. So now, how do we reach out to her? So we have a model where, like, the eye screening camps that we started in 1976, we used to reach out to them by these camps, but mostly these camps were on the weekends. So what happens during the week? Where will they go during the week? So that is where we started. The vision centers came into the idea of starting up in 2004, where now we have a primary vision center in all villages with population of close to 30,000, 40,000, where we are able to cater eye care to all the village people over there. And this is essentially manned by our mid-level ophthalmic personnel who are trained in a way to diagnose glaucoma, mild retina diagnosis, and reach out to us through the telemedicine network that we have. So now I'll be talking today only about our outreach work that we do. So the outreach actually was started by Dr. V while he was in his government service itself. In the 1960s, he had the opportunity to collaborate with Dr. John Wilson. And to tell here, Dr. John Wilson, he himself is a blind person. He is blind in both eyes. He was the one who was guiding Dr. V. This is Dr. Wilson's wife, Dr. V, in making sure all the efforts Dr. V was taking towards community outreach during his government practice. He made sure he took him in his own hands to meet the then Prime Minister of India, Dr. Indira Gandhi. And then under his pressure, the government of India started the National Prevention and Control of Blindness. During those days itself, Dr. V had the opportunity to publish the impact of community eye care and how it is helping people in India. And all these made them to start the outreach camp activities from the government side. So now the volume that we see, this is the number of camps that we are conducting per year in Aravind. Like we started with 118 camps in 1978, and now we do around 2003 outscreening programs every year. So through these 2003 outcomes that we are doing every year, we bring in around 121,000 surgeries that have been done through them. So this is entirely free for the patients. We are helped by the government in some ways, but majoritarily it is done by the hospital and few of the public partners that we have, who I'll be mentioning in the coming slides. So one second. Okay, so I'll just jump this slide. So how are we so productive in these camps? Okay, so if we are going to just stick on to cataract screening alone, this wouldn't be possibility. You need to reach out to the entire group of eye disorders across all ages. So we have camps from 0 to 4 age to 45 and above, ranging from childhood blindness, refractive errors, diabetic retinopathy, cataract screenings, and glaucoma also. So I'll just go back a little. So in the comprehensive screening camps, we have done, this is for the year, we have done 2015 camps. We have done close to 1 million surgeries and 76,000 lasers. With these lasers can involve retina lasers and as well as YAC-ups that have been done, or even YAC-BI for patients who we have found a shallow AC on slit lamp in the hospital. So I'll show you that later. There's a diabetic retinopathy screening where we have done 279 camps with 16,000 diabetic patients I found, of which 2,000 were identified with the DR. We have workplace screening camps. This workplace screening camp is something like we visit the industries where they are not able to get permission from their work area to come and meet a doctor. We go and meet them over there. This is generally in the age group between 35 to 45 where they may need presbyopic glasses. So, or we even found people who have diabetic retinopathies and glaucoma also in this age group. Then you have the school screening for children with refractive errors. And then we have ROP screening here, over here, and also here for children who have vitamin deficiencies also. So we refer them to the hospital. And this is the thing that we have so far that they have done in 2023, 2024. Like in the workplace camps, we have delivered 17,000 glasses. For children in schools, we have given them 10,000 glasses for refractive error known children. And then in pediatric children, we have found 94 glasses delivered and 428 children with pediatric defects, which have referred to our base hospitals. So moving on, how are we so sustainable? So we can't be sustainable without, when we started in 1976, you can't just barge into a village and say, you can trust me, you can come along with me, I'll take you, I'll operate on you, and I'll bring you back after 3 days and you'll get a vision. You need someone within the local community to help us gain the trust of the patients. So what does this local community partners do? The local community partners are our Lions Club, the Rotary Club, and all the philanthropic people in the village or in the nearby towns who have the financial power to help us. So they take care of initially the publicity of the work that we are going to do. Say we call them the camp sponsors. These sponsors will get to know that we are going to come this weekend, say 2-3 weeks ago itself. So they take care of the publicity. They take care of mobilizing the patients to the venue where the camp is going to be held. And they arrange, in case we need to go and stay, they arrange the accommodation for us over there and for the team. So they are the main pillars of our camp to be so successful. They are the main pillars for that. And then, so this is the publicity. So here there is an entire discussion happening with them. Like, where do you put these posters or these banners? If you see, this is being tied behind an auto, which goes around the entire 30-kilometer radius where the possible patients are going to come and sit for us. And these posters are placed in places where the maximum crowd are, like your downtown, your market area, your places where there are big like government offices are there, so that people will come and they will see us. They'll see these posters on there so that they get the awareness that we are going to come over there. So why are we doing this much of a publicity? Why are we taking care of this so much? Because in the coming slides, you will understand that a camp, when it needs to happen, literally it is a manpower across all the cadres of the institution. Like, you need the mid-level ophthalmic personnel to go with them. You need the doctors, you need the drivers, and you need opticians and counselors also to take and go. So when you're going to do that, when you're composing a team of them, based on what are you composing them? You're composing them based on the targets that we are given. Okay, 1 second. Like, this is the auditing that we do post-camp. Okay, I'll just jump a little and let you know what it is. So this is something that projected outcome, right? So based on this, the manpower will be decided. Let's say if the OP is going to be 500, what the camp sponsors and the organizers are expecting, like they'll tell in the Monday meeting to us that we are expecting 500 OPD and an IP of, we are going to bring in patients for surgery close to 100. We are going to sell glasses close to 30. Based on this, the manpower will be decided. So there are outpatient camps where we have seen 2,000 outpatients within 8-9 hours. And we have brought in 800 patients for surgery, which we complete in one single day and we discharge them the next day. So this requires extensive planning. So it is all based on the data that we have accumulated over years. So the meetings, like on the camp, what is the standard protocol that we need to do pre-camp, on the day of the camp, post-camp, and follow-up. So they are strictly monitored to maintain the quality of the patient's care as well as the surgical care. We are being strictly monitored based on those things. So this is the flow that you see in a camp in India. So in the meantime, when this happens, I'll just like to tell you that each and every camp that we conduct, like we have a pre-camp, like what is expected of the camp that is going to happen. And we have a post-camp analysis also, where, so in the post-camp, that's the most important part, because we are investing our time, the team going over there. And this is the flow of the patient care. This is the waiting area. This is one camp that we have shown you here. The registration details, like everything will be collected, and then the vision checking happens. And patient who needs refraction will be directed towards refraction first. And then the doctors see them in detail with the direct ophthalmoscope, IOP with the help of ICAT tonometer. These are all technological improvements that we have added to the existing thing. Patients who are selected for surgery, we do all the pre-op workup, like systemic workup there itself, blood sugar, blood pressure, everything checked. A detailed history of their systemic illness has been noted down. And then based on the eye that has been selected, the sister puts that tag so that the patient will be clearly explained that you don't take the tag off. Okay. And then this is something that we have started for the past 10 years now. Initially, we used to give the glasses 3 weeks later, which will come to them by courier. But now 95% of our glasses are delivered on the spot on there itself. We have ready-made cut glasses, certain powers that we are commonly needed. So we take it over there. And once the patient selects the frame, we just fit it over there, grind it a little and fit it over there. The base price of these glasses will be somewhere around less than $10 for sure. Nothing very expensive. So now in the hospital, what do we do? Because like I told you, Aravind went on quality. Okay. So patient-centric care, patient safety is utmost priority. So checking the eye every single time, wherever you need to be checked, keeps on happening. Like now, they check the band, they check the mark in the eye, check it with the K-sheet, and then the biometry with immersion tonometer, the dilated slit lamp examination, not to miss any intraoperative fundings. And then the next day they are operated and discharged the very next day immediately. So this is the routine. Like this we do on every Mondays and Tuesdays On an average, the entire Arundhak Eye Care system does around 2,000 to 3,000 patients on Monday and Tuesday, only the camp patients. So, and now this is something in awe for me, myself, but in reality, are we doing a good job? So that we need to evaluate. We make sure that we sit down with the organizers who are our in-hospital staff who coordinate with these camp sponsors from outside. We have this meeting every day. We make sure that the idea is to make sure like this number that you see over here, I'm hopefully showing you correctly. So now this means a lot. Only if you have patients more than 50-year-old coming to the outreach camp, will the camp related to cataract surgery be a success. When it's going to be a pediatric camp or a diabetic retinopathy camp, we will expect the same age, but from this, sorry. Oops. Okay. From this age group, 41 to 50 and more, it should be more. So in a workplace camp, we expect only 16 to 40 to be more. So this is a clear criteria. If this mismatches, the entire thing goes for a haywire because we wouldn't have the adequate manpower to handle those things. So next is like for this is a learning. Why did this camp go for a failure? Did the sponsor not meet the required advertisement needs, or did the camp organizer not go and meet them on time? So we literally do an autopsy of the camp that has been done on Saturday and Sunday. So like I told you, these are the benchmarks. And here you can see Dr. Kim, who is the Chief Medical Officer of Aravind Madurai. And this happens every single Monday. We make sure the camp organizer and the sponsor have literally done their homework properly for the camp to be a success. Like success, we don't mean 100% success. The target has to be at least 85 to 90% has to be met. So for us, so what is it for us as surgeons? Like our behavior in the camps, our behavior on the intraoperative table, because you need to do 13 to 14 manual small incision cataract surgeries per hour, depending on whatever the grade of the cataract it might be. So in the camp, it's like 2,000 patients from morning 7 o'clock to by 1 o'clock, you need to finish them. So you need to be on your best of a thing, but you can't shout, you can lose your temper. So all these things are monitored for us. And every week, every month, actually, this visual acuity improvement, we need to have it the best. You can't have it less than 618. So if it is this way, then the management makes sure we contact the patient, we call them back, we have a review with them to make sure that there is no error in the surgical side, and we treat them appropriately. So having said this, this is a blessing for the family, for us to be able to coordinate with so many people, to reach out to so many people and mingle with the general public to get them to the hospital to provide them care. And this is the family, Aravind family. You can see on the left is the second generation who are now currently heading it. They are all ophthalmologists except 4 people, 4 females here. And this is our generation. We call ourselves the 3G. And in this, only 2 of them are non-ophthalmologists. The rest of them are all ophthalmologists, and they are all head of departments, and 2 or 3 are now currently running the institutions. So thank you again. Thank you for your patient listening of this.